Hey everyone, it's Naveen again, the Nephrology and Critical Care Fellow, and this is part 2 of the Nephrology in the ICU series. I wanted to talk this time about hyponatremia, something that we come across very often in the ICU as something that is generally critically in critically ill patients, and I think it's really important for us to recognize the physiology of hyponatremia and how we can target it so that we actually have a plan. And the main reason for this is more and more evidence is really suggesting the times spent managing hyponatremia going back and forth because we don't totally understand the physiology often leads to increased length of stay in the ICU. And now there's some argument that perhaps the increased length of stay is associated with increased complications of correcting hyponatremia. And so I want to give us all some sort of framework to really adequately attack hyponatremia in a controlled manner. And really, we shouldn't be seeing these patients in the ICU for more than 2 to 3 days in the ICU on average. And I think that if we have this system, we really will be able to make that a goal and safely get patients discharged and correct their physiology. So I'm going to start by giving us 3 principles that we're going to go by through the rest of this talk, and I'm going to go into these in a little bit more detail once I've given you the principles. The first is that hyponatremia is what's called a tonicity problem, okay? Classically, we think of this as a sodium problem, but you're going to come to realize shortly that this is not in case the fact. It's actually a water and tonicity problem. The second rule that we're going to go by is that ADH manages our urine osmolarity. Okay, and we're going to talk about the triggers for ADH. The third is that RAS manages our urine sodium and chloride, and this is going to be important for us to understand effective arterial blood volume. All right, so let's look at the first thing. What do I mean by hyponatremia is a tonicity problem? Let's imagine that we are, in fact, just a bucket. That's all we are. And in this bucket, we have salt. These we can call our sodiums just to make things, a little easier to understand since we're talking about hyponatremia. Well, it turns out hyponatremia is not a problem of having too little salt. It is the problem in fact lies when all of a sudden that there is an excess ratio of water introduced into the system that does not contain the same concentration of salt. And what this ends up doing is diluting our salt content in a much larger space of water. And so our sodium is diluted, okay? So it in fact is not a problem of sodium because the sodium is oftentimes not the thing that we're trying to manage. It's rather how can we correct this ratio between water and salt, okay? And let me put this in another way. So normally when we think about hyponatremia, or we think the consequences of hyponatremia, we think nausea, vomiting, altered mental status, seizures, but another thing that we think about is what happens if we overcorrect the sodium too quickly. Okay, so I'm going to draw a space where we have the extracellular space and the intracellular space. Normally, when we measure a BMP, we're measuring the extracellular space inside the blood vessel. Okay, the extracellular space or extracellular portion of the intravascular space. But we're not measuring the intracellular space, and that's why we get a sodium of 140. You may recall that in a cell, normally we have very high K that makes up the most of our intracellular osmolarity, but inside the blood vessel we mostly have a lot of sodium, which makes up our the majority of our extracellular osmolarity. Okay, so the problem lies when we have say, for example, hyponatremia, where we have very few osms in the extracellular space, and perhaps is chronic, and so now it's matched by the intracellular space. And we correct the sodium too quickly, meaning that the concentration, we've removed this water, now the concentration of sodium in that same amount of volume taken is increased. Well, what does this do? Well, it triggers a water shift from the intracellular space to the extracellular space in order to dilute the extracellular space. And then you get osmotic demyelination syndrome, right? So, in fact, in reality, what we are worried about is when a cell, such as the brain cells, change in shape and either shrivel up or get too big in the case of cerebral edema if we went the other way. This is what worries us. It is the water movement into and out of a cell rapidly that worries us. And what determines water movement? What determines water movement is the tonicity outside and inside the cell that pull water outside and inside the cell. And normally we're in a balance. But when there is a shift on one side where that imbalances the other, well, our natural mechanism to balance that shift is water movement across the cell membrane. And if that water movement is too fast, we run into trouble. Okay, so what does tonicity mean? Well, tonicity we have to actually separate out from osmolarity. Okay, osmolarity is the number of osmoles inside a volume. Okay, so we generally think of this as millimoles per liter. Okay, not to confuse with osmolality, which is per kilogram. However, not every molecule is useful in the setting of hyponatremia. We want molecules that drag water across the membrane, okay? We want molecules where the molecules themselves aren't what diffuse across the gradient. We don't want that. We want molecules that instead make water move across the membrane to them. So these are molecules, osms, that are highly partitioned and kept in place. So some examples of that are sodium, okay, glucose, things that are kept in place. But another one that is not, for example, kept in place is, let's look at urea. So urea, if it builds up in one space, instead of water moving to it, it very easily moves across the membrane in order to balance itself out. And therefore, water doesn't have to shift. But urea is an osmol. It's just not an effective osmol, meaning that it does not drag water with it. So we don't call it a tonic molecule. We call it an osmol, but an ineffective osmol. So what we care about are effective osmols. So now why is hyponatremia the problem that we deal with all the time? Well, it turns out that in our serum, if you remember calculating your serum osmoles, it's 2 times your sodium plus your urea divided by 2.8 plus your glucose divided by 18. And this is our calculate osmoles. And this sodium makes up the majority of our osmoles in the extracellular space. And so therefore, we most often come across disorders of natremia, disorders of sodium, because it's just the most common effective osmol in our serum. But in reality, any effective osmol can be a problem. Any effective osmol can be a problem. It's just sodium is the most common in the extracellular space. Okay, so again, in summary, we sort of beat this to this drum a lot, but the important thing that we recognize is that hyponatremia is not in fact a sodium problem, but it's a problem of tonicity. The changes in sodium concentration lead to abnormal water movement that we worry about, okay? And that leads to cell destruction. and that's what we try to avoid. Okay. The second rule that we talked about is ADH is related to our urine osmoles. So when we manage hyponatremia, we're going to get 4 urine lab studies for sure. Those urine studies are urine osmoles, urine sodium, urine chloride, and then not shown here is urine potassium. For the purposes of this, I'm not going to really go through why urine potassium is important. I think that that's more of maybe an advanced topic, but but these are the 4 studies that you get. The reason we get the urine osmol though is it tells us how active ADH is. So ADH is important for concentrating our urine. So if our osmoles are high, then our ADH must be high. If our osmoles in our urine are low, let's call this urine osmoles, then our ADH must in fact be not very active. That's the rule here, okay? But what triggers ADH? The first trigger for ADH is changes in the serum osmolarity. Okay, changes in the serum osmolarity. Turns out that every single one of us have an osmolarity usually within this range, 283 to 293. I might be slightly different than you by 1 or 2 points, but we all have a set point that we defend very, very closely. Now, in that bucket analogy here, where you have a set amount of osmoles, if this is our normal state of being and we suddenly increase our osmoles, well, the body's reaction is, how can I then increase my water to dilute back my osmoles back into a state, a steady state, okay? And so here, ADH must then become active in order for us to trigger 2 responses. One is thirst, so we start drinking more water, and 2 is the kidneys. All right, the kidneys will then retain water and make concentrated urine. So they are making concentrated urine because they're trying to retain as much water as possible in order to dilute these osmoles back. Okay, that's the bucket analogy here. But on the flip side, if our urine osmoles were to suddenly decrease, say we're not eating very well or we're peeing out these osmoles really rapidly, and our concentration of our serum osmoles are decreasing, well then the body's job is then to, like the bucket, pee out water, just pure water. And how does it do that? Well, ADH shuts off, and we shut off our thirst, and the kidney beans start making low urine osmol or very dilute urine so that we pee water, as much water out as possible, and we reconcentrate our serum osmoles, okay? So this is the most sensitive trigger for ADH, but it's a weak trigger for ADH relative to the second trigger we're going to talk about. And that second trigger is low effective arterial blood volume, okay? Low effective arterial blood volume is the most important one, and so I'm going to give it a star. And this is often the pathology that we deal with a lot. What does this mean? Well, it turns out evolutionarily, when we are in a perceived state of low effective arterial blood volume, usually it was, say, volume contraction because we're hemorrhaging out in the world. Well, our body tries to protect us by increasing RAS. And the idea is the adage that water follows salt. And so we would try and retain sodium as best as possible, and water follows. But if we stay in a very persistent low effective arterial blood volume state, it turns out that angiotensin helps trigger ADH release. And so you have ADH release, and that helps us make concentrated urine. And we try and retain water. But the problem is we don't retain the salt with the water, and so it eventually dilutes our body, okay? Now, it doesn't matter that we're diluting if we start dropping below this range, 282, 281, 280, and so forth. It turns out this overwhelms the trigger here to the first trigger to shut off our ADH, and we still have very active ADH. It takes longer to activate this trigger, but it is more potent and powerful than the first trigger, meaning that it overwhelms the first trigger. So even though we become hyponatremic, we don't start diluting our urine because this trigger wins out. Okay, and then the third and fourth trigger that I'm going to mention is nausea and pain. Now, these are triggers that cause ADH release. These are ones that we should know about, but these individually do not cause significant hyponatremia. They may be additive effects, but generally we shouldn't be calling, hyponatremia is less than 130 related to just nausea and pain. We should really be looking for other etiologies, okay? All right. The third rule is that RAS shows us in the form of urine, sodium, and chloride. Okay, so I starred the second trigger, low effective arterial blood volume, because it is one of our really critical branch points that help us understand what is the etiology for the hyponatremia. And so we must interrogate any sign of RAS activity, and the big one is urine, sodium, and chloride. In a state of high RAS activity, we become sodium avid, and so our sodium in our urine becomes undetectable. Now we have the capability of fully absorbing sodium and chloride, and so it really should be undetectable. Some centers are less than 10 on their studies, and some centers are only less than 20, but really it should not be detectable. It may be 15, right? But that means RAS is not as maximally active as we expect it to be, and you really should start looking for other triggers. I know traditionally they may teach you greater than 40 is not very RAS active or RAS avid, but sodium avid. But I really want us to urge thinking that the kidneys are very, very capable of retaining sodium, and so if we get a state where our urine sodium is detectable, you should think that RAS is not as maximally active as we hope, and we should look for a different trigger for hyponatremia. Okay, all right. So these are 3 rules that I want us to commit, and we're going to keep coming back to over and over again. All right. The next thing that I want to discuss is something called Edelman's equation. Edelman's equation is maybe considered like the holy grail of hyponatremia management. I think this is what really separates understanding hyponatremia from the algorithm that we're classically taught as, residents. And so what do I mean by that? Back in the older days, it turns out we noticed this thing that in patients who had low serum sodiums, that when we gave them potassium, we started to have improvements in our sodium. And so this guy named Edelman wanted to try and figure out the relationship between the concentration of sodium in our extracellular space in our serum with the relationship of actual sodium, because obviously sodium must be the total number of sodium molecules in our body must be related to the concentration of sodium, but also with potassium. And so how he did this was he labeled a bunch of radioisotopes, sodium and potassium, allowed it to move through the body, redistribute, and then back calculated sort of the distribution of the sodium and potassium. And ultimately came up with an equation that mimics mx plus b, where m was close enough to 1 and b is a close enough to 0 thing that we simplify this equation to something like this. Okay, in reality there was a slope term and there was an intercept term, but we got rid of it because it was negligible. And so you see this equation here where serum sodium equals the total number of exchangeable sodium and exchangeable potassium in the body. So this is the sodium and potassium that exist intracellular and extracellular. Remembering that we do not measure the intracellular sodium and potassium regularly because our serum BMPs are only measuring our extracellular sodium and potassium. So this is something that we can only calculate, for example, by doing the same radioisotope study. This is something that is generally unknown to us in the beginning. And the bottom terminology is total body water. Okay, so again, this really goes to that bucket analogy that we are full of these osmoles, and these osmoles are diluted in a set amount of water. In the human case, total body water. Okay, and this relationship determines what our serum sodium is going to be. Okay, now the best way of thinking about hyponatremia is through the lens of this equation, where we think about the numerator here and the denominator here. And there's really 4 scenarios that are going to pop up. The first scenario is the true volume contracted state. Okay, so situations where this is the case is something like nausea, vomiting, diarrhea, etc., right? Overdiuresis, right? So these are situations where a patient becomes incredibly volume contracted, right? And so these naturally trigger RAS activity. And over time, ADH starts to become active. So while this absorbs water plus salt, here we're only absorbing water. And so when we add the net is that we are absorbing more water, reabsorbing more water than we are salt, and we get hyponatremic. Okay, so what does that mean for the equation? Well, in a volume contracted state, our serum sodium is going to change because our exchangeable sodium and potassium over total body water is changing something like this. And why is that? Well, nausea, vomiting, diarrhea, and diuresis are leading to salt losses, but then our body tries to retain water. Now, there is a caveat to this that I think we need to be aware of. Normally, nausea, vomiting, and diarrhea, these are situations where we actually are losing hypotonic fluid. Okay, what does that mean? So actually thinking about this situation, if we lose this much salt through our nausea, vomiting, diarrhea, since it's a hypotonic fluid, meaning that it's not 300 osms, it's something less than 300 osms, usually somewhere between 50 and 100 osmoles, we are actually losing a lot more water than we are losing salt. And so Edelman's equation would then predict that we actually start to get hypernatremic. And in fact, that is what happens when a person has no access to water. When someone has access to water, sorry about that. When someone has access to water, they can replenish some of that water, but they have trouble eating the salt back, right? So think about what mom taught you to do when you were sick. It's drink chicken noodle soup. Well, chicken noodle soup, I guarantee you, is not as salty as your blood is. And so maybe you get a little bit of salt back, but you're getting a lot more fluid than salt while you're still losing salt and water, okay? And your body's in a state of trying to retain as much water as possible. And so you eventually get to a state where you are still losing more salt than you are losing water. And you get hyponatremic, okay? So that's the volume contracted state. The volume contracted state is a situation where Edelman's equation would predict that you lose more salt than you lose water. All right. Let's look at scenario number 2. Scenario number 2, Scenario number 2 is the volume overload state. Okay, the volume overload state as predicted by Edelman's equation would be something like this. So if our volume is increasing, sorry about this. If our volume is increasing, we know the bottom is definitely increased, right? Well, this would dilute the serum sodium by itself. All I know is that the patient, because they're volume overloaded and water follows salt, that means I know that they have an excess amount of salt already in their body, but to become hyponatremic, they must have even more water than they have salt in their body. That's the only way the numerator divided by the denominator leads to hyponatremia. Okay, and why might this happen? Well, again, in many states such as heart failure and cirrhosis, you get this low effective arterial blood volume state that triggers RAS activation. And this RAS activity will ultimately lead to increased ADH activity. The trigger for this RAS is different in heart failure and cirrhosis. Um, uh, and but the key is that eventually over time you start retaining more water than you retain salt despite this low effective arterial blood volume state, and ultimately you get hyponatremia. Okay. The third situation that might arise, the third of four, is the euvolemic state. And this, as predicted by Edelman's equation, is that you shouldn't have a change in salt because you're still euvolemic. And so salt is unchanged, but your water for some reason is increased in the bottom. Okay, this means that ADH is likely active, but there are a few situations where this that you get something that appears like this, but in reality, um, um, there are some niche scenarios where it appears to look like there's ADH activity, but maybe that's inappropriate. But maybe there are some other reasons why ADH is active, and it turns out it could be appropriate. And just a hint, for example, would be adrenal insufficiency. But okay, the fourth and final scenario before we start to um, compare the scenarios is the low ADH state. So there are occasionally times where you have a hyponatremic patient, but when you measure the urine ADH, their urine osms are actually on the low side. Okay, and what does low mean? It means anything less than 200. If we are hyponatremic and trying to do the right thing, we will pee dilute urine, as dilute as 50 osmoles per liter urine. Okay, if we have good working kidneys. Now, if we don't have great working kidneys, we're going to give a little bit of fudge factor, and it could be anywhere between 50 and 200. But if we're peeing a concentration of urine that's generally more than 200, perhaps we should start thinking there's an alternate etiology for there's an inappropriate amount of ADH or an appropriate amount of ADH, but there's some amount of ADH that's active. Okay. But when we see a state where actually the urine osms are low and we see, oh, wait, the body is trying to do the right thing and reconcentrate the sodium by peeing dilute urine, well, then we have to think about a very niche differential here. And that niche differential is primary polydipsia. There's nothing wrong with what the kidneys are trying to do, but they're unable to do so because they're being outstripped with their ability to do so because we're drinking so much in comparison to what we're able to pee. Or you get situations like the tea and toast diet. And another form of this, maybe you can consider beer hypopotomania as sort of a similar situation, right? Um, and these are situations where your urine osmoles may be low. And occasionally, this can happen if you also have obstruction. You could suddenly get a really dilute urine because the kidneys are trying to do the right thing, but they're just not able to get the fluid out of their body, and so you get an obstruction. And we'll talk about that a little bit in a little bit when we talk about how to evaluate. Okay. So these are 4 scenarios that you're going to come across in relationship to Edelman's equation. I did forget to explain how Edelman's equation would look like as this. So it turns out that really our salt status is not really the problem, but it's that we are drinking too much water and we are trying to do the right thing, but by peeing out dilute urine, it's just we're drinking water to the point where we're outstripping our ability to dilute ourselves, okay? All right, so let's summarize these four and then talk about how RAS and ADH would be active for them. So the first situation that we talked about is volume contraction. The second was volume overload. Volume overload. The third situation was euvolemia. And the fourth situation was urine osms are low. Okay. In the volume contraction and overload state, we are experiencing low effective arterial blood volume, and so RAS is appropriately active in both of these states. What does that mean? Well, based on our rules that we talked about before, RAS is related to urine, sodium, and chloride. So urine, sodium, and urine chloride are going to be undetectable. At our institution, that's less than 20. And this is the same case here, should be less than 20. So RAS should be high in these two states, okay? Because while we're retaining water, as we talked about in both of these situations, our ADH is going to be high. What does that mean? Well, our urine osmoles are going to be greater than 200 in both of these situations. All right, our urine osms are going to be high in both of these states because our ADH is high. So how do we tell the difference? Well, this is where I'm going to go in biased because my urine studies tell me that this patient is in a low effective arterial blood volume and their ADH is high. So now I'm going to go based on history and exam to understand which of the states this is. For example, if I know they have a history of heart failure or cirrhosis, that really helps me out in understanding what's going on. If I know that they just got chemotherapy and are having constant nausea, vomiting that's uncontrollable, but they're able to drink water, well, then that helps me going on. My physical exams also are going to tell me as well, right? So volume contraction and overload are going to look very similar, but I go in biased when I evaluate the patients. And that's how I use these urine studies to really clue me into what is the driving physiology. And this is particularly important when you think multiple things could be involved. For example, the patient with cancer who's on SSRIs and it's lung cancer, you may think, okay, and they just got chemotherapy, well, then that opens them up for many different situations of hyponatremia. The urine studies are what's going to tell me the driving physiology, not necessarily the um, the all the all the physiology types that could be contributing, okay? All right, the third situation is the euvolemic state. So RAS should not be active, okay? So my urine, sodium, and chloride are going to be detectable at our institution greater than 20. But for some reason, ADH is active, right? So our urine osms are going to be greater than 200 in this situation. And this is most commonly our SIADH, our nausea, and our pain. Okay. There are a couple situations that mimic this. One is adrenal insufficiency, where we're actually in a volume contracted state. The problem is because our aldosterone system is broken, we cannot show that RAS is active, so we start to have a detectable sodium and chloride. You just have to be aware of it based on history that this is part of the differential when your urine studies look like this, okay? So I'm going to show you that even though you're volume contracted, your adrenal insufficiency fits under these urine studies. And then hypothyroidism is another example that fits here. It turns out TSH and ADH release are related. When someone has very low TSH, you start to have increased ADH activity. as one mechanism. Another could be heart failure, for example. And it's same with adrenal insufficiency. It turns out when someone has low corticosteroid activity, there's inhibiting factor of corticosteroids and ADH. So when you lose corticosteroids, you have increased ADH activity, and so you get increased water retention in those situations as well. And the fourth and final case that we talked about is where urine osmoles are low. So ADH, by definition, is not very active because the urine osm is less than 200. And RAS is generally whatever it wants to be, but it's not usually active. And so you usually have a detectable sodium and chloride. And again, as we talked about, the situations where this might be is tea and toast or primary polydipsia, right? So these are sort of our four scenarios that I want us to divide based on our urine study. And again, I'm trying to beat the drum here that when I evaluate a hyponatremic patient, I purposely go in biased based on my urine studies and then actively use my history to prove my urine studies wrong. Or guide me in which of the first two etiologies it could be if they are matching urine studies. Okay, so again, in summary, Edelman's equation helps us understand the different possibilities for hyponatremia based on the relationship of salt and water in our body. Okay, and it turns out these are managed by RAS and ADH. And so when I'm evaluating hyponatremia, I sort of have an order for evaluating hyponatremia. The first thing that I check is going to be my serum osms because I want to make sure that they are true hypotonic hyponatremia. Again, hypotonic being the key, right? Let's make sure this is an increased protein or lipid state or glycemic or ethanol type of thing. Let's say we are true hyponatremia. The second thing I'm going to look for is an acute kidney injury. Now, why am I looking for an acute kidney injury? Well, it turns out all this physiology is useless if you don't have working kidneys. If I did a bilateral nephrectomy in you, then you would no longer have the ability to pee out water. So as long as you're drinking water, you're going to dilute yourself. So an AKI is sort of, okay, well, we're sort of done with the evaluation here because it's the AKI most likely leading to it. Now, of course, this has to be an oliguric anuric acute kidney injury. Generally speaking, kidney injuries that are mild are not going to be the etiology for your hyponatremia. And so don't put complete faith in this, but again, I want you to always keep in mind that AKI sort of cuts our evaluation short here. The third thing that I'm going to look at is this an ADH appropriate is ADH active? And how do I do that? Well, I look at my urine osms. Again, rule number 2 that we went over is that urine osms tell me how active ADH is. And if ADH is active, I ask myself, is RAS active? Because this helps me understand, is it an appropriate ADH state or an inappropriate ADH state? Anytime RAS should be active, it's an appropriate ADH state. Okay. And this is how I then get to my differential for, okay, RAS is active, therefore I'm in a low effective arterial blood volume. That automatically makes me a volume contracted or volume expanded state. Which of the two is it if my ADH is active? On the flip side, if my RAS is not active, well, then now I'm looking at, is this SIADH or is this going to be something like adrenal insufficiency or hypothyroidism in the right clinical picture? And then, oh, ADH is not active. Well, now I know it's primary polydipsia or tea and toast diet, right? And so I cut short all of the evaluation, particularly because many of these patients that get hyponatremic are going to have multiple possibilities on their differential, but my urine osms really let me cut loose many of those. My urine studies really let me cut loose many of that differential and speed up the evaluation. Okay. So now we've talked about how we actually diagnose hyponatremia and how we sort of stratify hyponatremia. I want to talk instead how we treat hyponatremia. I think this is the most important thing for when it comes to the ICU, because we get some critically low sodiums where we're sort of in a picture um, of, uh, you know, how aggressive are we going to be when we manage these patients. Okay, so let's first talk about our correction rates and our targets. So first we have to determine, is this acute versus chronic? If a patient is in an acute hyponatremia, it means less than 72 hours ago we knew they had a normal sodium, and I guess some people will say less than 48 hours to be very, very careful. If they're in less than 48-hour period, you can correct it as fast as you want, doesn't matter. But on the flip side, if they are in a chronic state, which most of our patients are, because we didn't have a sodium less than 48 hours ago in the majority of our patients, then we have to correct it on a slower scale. Now, but how slow do we have to do it? This is what's debated. In fact, for decades it's been debated. Some schools of thought are only 4 to 6, and some schools of thought are 8 to 12 in a 24-hour period. Now, I will tell you that me, stylistically, I am the more aggressive sort of intervention. Um, why do I say this? Well, osmotic demyelination syndrome is incredibly rare. Perhaps it's underreported, but it's incredibly rare. There are things that make people higher risk for osmotic demyelination syndrome that we can talk about in a quick second. But uh, in reality, there's also some suggestion that perhaps patients who end up in the ICU for a lengthier period of time are more likely to be associated with osmotic demyelination. I think this is a selection bias, and I don't really trust the data myself, but there are case reports where we only correct by this 4 to 6 and we just swing a lot. Meaning that we corrected by 7 and then we give D5W, and then now we've corrected only by 2 by the end of the 24-hour period. Or we gave DDAVP and really slowed things down, and we just lengthened the course of time, and these swinging shifts of sodium ultimately led to what we think is ODS. I think that's more plausible, the shifts in tonicity. Rapidly changing, swinging from one end to the other might be what causes it. And so what's critical is that we pick a strategy and we stick with it and just move forward with it. And so my strategy, personally, the way I manage it in order to get them out of the ICU quicker, is I correct them either by 6 to 10 if high risk, or I correct them by 8 to 12 if low risk. What are risk factors for high risk? So a high risk patient is someone who might be female, have cirrhosis, have hypo-K, malnutrition, ethanol or alcohol, significant alcohol use. These patients, are usually malnutrition and have hypo-K or have cirrhosis, so it's probably related in some way. And then, or have sodiums less than 120. All right. Oops. Sodium's less than 120. So if I see these risk factors, then I generally only try and correct by 6 to 10 in a 24-hour period. Okay, I try and only correct by 6 to 10 in a 24-hour period, and I do this for every 24-hour period. Now, why do I do a gap of 4 versus a gap of just 2? Well, my thought process here is I try and give a nice landing pad. This is sort of how I was taught by one of my mentors. When we have a goal of something as stringent as 4 to 6 or 6 to 8 or 8 to 10, 10 to 12, well, we really try and hit it. And so as the day goes by in a 24-hour period, say I started out at 110 and my goal was 120 for the day. Say I got to 116 in the first 4 hours. Well, then we panic all of a sudden. We're like, oh, by the time we get here, we're going to be like 130. So then we give D5W, and then the next one is 110. and then the next one's 116, and we're like, okay, maybe we leave it alone, and then it's still 116 because we did nothing, and then we've undershot it, right? We really panic, and this is made even worse when all of a sudden we're targeting a very stringent goal of only 4 to 6. For example, let's say our goal was 110 and we're trying to get to 116 maximum. Well, here we already got to 115 and we're like, oh, we're definitely going to overshoot now. And then we go back and forth, and then we get to 111, and next we're still 111, so now we give 3% saline, and we actually overshoot to 118. We get worried, and then we give D5W and drop it back to 115 or something like that. It leads to a lot of swinging when we're super stringent. And so my goal is, well, the evidence really doesn't suggest a gap of 2 versus a gap of 4 is worse, as long as I'm within my limits that I've set for myself, and I'm trying to move forward, commit to a strategy and move forward. Everything usually stands out okay, and so that's why I usually use a gap of 4 in a 24-hour period. So for example, if a patient came in at 110, by the end of the day, I'm going to target 116 to 120. And that gives me a nice landing gap to prevent overcorrection, help keep me calm, based on if my sodium comes out weird or not. Okay? All right. So we've talked about correction rates and we've talked about lab values. But the next thing I want to talk about is how to monitor the labs. I generally do Q4 BMPs or sodiums. I don't do this Q2 hour business. Main reason, by the time the lab comes back, usually you're already like halfway to the next lab or more than halfway to the next lab. And realistically speaking, we're busy. It's really hard to react this quickly. And so I generally just stick with the Q4 hour BMP. And for me, the strategy works out because I commit and really try not to overreact by keeping this sort of wide landing pad for my sodium. So if I'm doing Q4 BMPs and I started at 110 and 4 hours later I'm 115, right? And my goal for the day was 116 to 120. I also set a second rule for myself, and is that I don't overreact. So say this is at time 0, this is at time 4 hours. What I do is I wait for my next lab. If I'm really worried and I think I'm overcorrecting quickly, this is where I ask them to draw another lab immediately as opposed to wait for the next hour. So maybe I'll do time 5 hours, or if I'm really feeling confident or that day, I might say time 8 hours. And then I just see what the next sodium is. Now, if the next sodium is 120, right? Okay, now I have a trend, and I'm going to give some D5W and get myself back down to 118 for the next, the next lab check at T12, and then so forth, T16, and then T20 to 24. Okay. What's the key here? What I'm saying is I wait for 2 BMPs to give me a trend. 2 BMPs or 2 sodiums to give me a trend to know whether or not the lab is real. Unfortunately, as we're doing this, we might be giving 3% saline, we might be giving D5W through an antibiotic or something. And if the lab is drawn from the port or in the arm very close to where that was given, it may mess up our BMP. And so we overreact. And false labs are also not uncommon, unfortunately. And so I try and wait for 2 labs in order to have a trend. Now there is a caveat to this rule, and that caveat is I also look at urine output. All right. Based on Edelman's equation, we know that the serum concentration of sodium is the total exchangeable potassium and sodium in the body over total body water. All right. And our goal, that bucket analogy, right, was how do we create a faucet for H2O to leave so we can reconcentrate our sodium back in our blood, right? It's not how can I add sodium, it's how can I reconcentrate the sodium that I have back in our blood. So if I go from 110 to 115 and my urine output that's recorded, and I can believe it, is something like 50 cc's an hour, which is not very much, then I don't believe this lab. It makes 0 sense, okay? Unless I was giving 3% saline, it makes no sense. However, if I'm actually peeing 200 to 300 cc's an hour, then I'm going to believe it. Why? Because I could actually calculate this, use this equation to calculate, and determine what my expected serum sodium is going to be. So if I'm peeing, say 4 hours later, I've peed 1.2 liters, well, and I started at a sodium of 110, I can back calculate based on empiric calculation total body water. I can back calculate what my exchangeable sodium and potassium was. Exchangeable sodium and potassium was, right? And then I can subtract my urine output from total body water and recalculate what my new serum sodium should be. So for example, if I take a 70 kilo individual, 70 kilo male, that's 40 years old, I empirically know that their total body water is 0.6 times their weight in kilos. For a female, it's 0.55 times weight. And for anyone above 60, for anyone above 65, sorry, 65, it's 0.5 times their weight. But let's say I take a 70 kilo male who's 40 years old. Well, then I know their total body water is predicted to be about 42. And so then I can recalculate X up here, which is their exchangeable sodium and potassium, right? And depending on what X is, so X equals 110 times 42, depending on what that is, I can rearrange this equation. Well, what is my new serum sodium going to be if my total body water changed from 42 minus, say they peed 300 cc's for 4 hours, so now they're down 1.2 liters, right? And I've calculated X up there. Well, then I can redo this math and calculate what my new expected sodium is going to be, and I can trust that this is possibly a real lab, and so I'm going to act even on that first BMP as opposed to waiting for 2 BMPs. Okay, so in summary, the way I approach lab values is I get Q4 BMPs and I try not to act on a single BMP. I wait for 2 BMPs to guide me unless my urine output is very robust. Okay, unless my urine output is very robust. All right. Now, we've talked about correction rates, correction goals, and how to obtain labs and how to use urine output to help you determine what the expected changes in sodium is going to be. Let's now let's now talk about sort of the two approaches to actually managing sodium. The two approaches are generally considered the controlled approach and the reactive approach. The controlled approach, I think, is the one that's most common in the ICU. It's the one that thinks about the physiology the least, but it's very controlled. And ultimately, we fix the sodium without fixing the underlying physiology. And so once we stop doing this approach, the underlying physiology will return. And so to me, this is not my favorite stylistically, but it works very well and gets them out of the ICU very quickly and make sure we get them out of the danger zone in a sort of a manner that is not, you know, sort of, you know, like dependent on whether or not their physiology is what we predicted their physiology to be. So this is the DDAVP plus 3% method. So what is this method actually doing? Again, thinking about Edelman's equation, we are a ratio of salt and water in our body. And normally our goal is how can I pee out water and reconcentrate my sodium, okay? The controlled approach, it throws all of this out the window and instead says, okay, we're going to shut off the faucet. How do we shut off the faucet? Well, we maximally concentrate our urine. We use DDAVP to make our urine osm just go up, up, and up. So we pee very little, okay? Because we pee very little, our volume is not what's going to change. So if we were to leave someone like that, their serum sodium would never change, okay? DDAVP doesn't make sodium go down, it just makes sodium stop moving. All right, that's a key because we are no longer able to reconcentrate ourselves. If we left it like that, then we'd run into trouble. So instead what we do is we give 3% saline. So we effectively brute force the sodium back up by giving 3% saline. That's how we fix the correction. The problem is when the DDAVP wears off, well, we haven't fixed the physiology, and so next is the job. You have to fix the physiology to prevent this from recurring. Okay. However, if you do this properly, this is very easy to predict and control, and you can sort of set this on autopilot without worrying. This is great if you're incredibly busy or if you're worried about someone who's going to overcorrect. And we'll talk about those overcorrection scenarios at the very, very end. All right, so how do I dose the 3% or the DDAVP first, actually? Well, generally speaking, they can be 0.5 micrograms to sorry, not micrograms, milligrams to 2 milligrams. Okay. Dosing is the general starting doses that you're going to use. For smaller people, they probably don't need very much. What you're going to do is give a dose of this and then quickly check your urinosm. If it's working properly, the urinosm should start to increase. Okay, preferably above 600 is your goal. Now you can give a lot more. Say it's not working. I had to give 3 milligrams at a time, and the guy was still peeing 100 cc's an hour, of urine that was only 450, 500. Well, the maximum dose of DDAVP in the day that I've seen recommended is something less than 20 milligrams per day. So you can think about, you can just keep giving it over and over again. Now, DDAVP has this sort of weird pharmacokinetics, where the more you use it, the longer it lasts in the body. Okay, and normally it just has a half-life of 2 to 5 hours, but the more you use it, the longer it can last. Unfortunately, I don't find this predictable myself. I've seen it last sometimes for a day or two in a patient after just a single dose. But this is sort of the theory behind it: is you give the DDAVP multiple times a day, you check the urinosum, make sure you're getting concentrated urine, and then you're going to give the 3% saline at a rate of 0.5 mLs per kilogram. So if I have a 70-kilo individual, I'm going to start at a rate of 35 mLs per hour of 3% saline. Okay, how did I get this number? Well, this is sort of empirically calculated. Let's think about a patient whose sodium is 110, and then they are a 70-kilogram individual male with 42 liters of total body water, right? We can calculate X, all right? X comes out to something let me just quickly do the math. Comes out to 4620, right? In a 24-hour period, this patient is going to get 840 cc's of 3% saline. Okay. Now we know 3% saline is 513 milliequivalents per liter. So if I'm giving 0.84 liters, then I can calculate how many milliequivalents I'm getting. And so this comes out to 430 milliequivalents of sodium. All right. So using Edelman's equation, again, the total exchangeable potassium and sodium over total body water, right? I can add the 430 to the 4620 here, and roughly get 5050 as my new top, right? It'll become 5050, and my total body water is going to change by 0.84 liters, and so I become 42.84. And if I do this math here, divided by 42.84, you get 118 milliequivalents. And remember, I said that our goal is to change by 6 to 10 in a day. So I've changed by exactly 8, right? So it's perfect, it lands perfectly. Now, of course, patients are different than just their test. They might be getting antibiotics that's diluted in something, or and this affects everything, right? So what I do is I go based on my Q4 BMPs or whatnot. I'll adjust my rate. If I'm correcting too quickly, I might drop down. If I'm correcting too slowly, I might increase the rate. But my starting rate is going to be half ml per kilogram of 3% saline, okay? Now I'll say one last thing. You can use Edelman's equation to know how much to give a person in an acute scenario. Say that they have nausea, vomiting, or seizures or diarrhea, and you're actually trying to bolus them and get them up quickly to see if their symptoms improve from the hyponatremia. I see all the time you give, 50 mLs or 100 mLs of 3% saline based on vibes, and like there's no better reasoning other than it's just based on vibes and you hope it's going to work. Remember, there's 513 milliequivalents of sodium in a liter of fluid, and so if you're only giving 100 cc's, you're giving roughly 50 milliequivalents of sodium. You're not budging them at all. Okay, it took 840 to go up by 8, so if you give 50, you're not going to go anywhere. So how do you determine how much to give them? Well, what I do is 3 mLs per kilogram is how much I bolus into a patient. So if the average 70 kilogram patient comes in, I'm giving no less than 200 cc's of 3% saline in order to get them out of the acute scenario. What does this do? This bolus only increases them by roughly 2 milliequivalents. And again, remember, when we did 840 cc's, we went up by exactly 8. So if I'm giving roughly 1/4, then I'm going to go up by 2 milliequivalents, okay? So 3 mLs per kilogram is your bolus dose. Half an ml per kilogram is your maintenance rate. Okay, this is the controlled approach. This is not the approach, again, that I like to take. We're almost... All right. Sorry for that. I'm stitching this in, redoing this portion here. So the second approach to treatment is the reactive approach. The reactive approach is a relatively more thoughtful approach in that you have to be paying attention, and this is the approach because it's not controlled. You can't really just walk away, and it uses the Q4 BMPs, the urine output, but what its job is to target the underlying physiology, fix the underlying physiology, and therefore the patient shouldn't really backtrack, as long as there is a plan of fighting this underlying physiology. And so what does that mean? Well, let's go into how I react. So first I figure out, is ADH active or not? So say ADH is inactive. Well, this is the easiest ones to evaluate. These are your primary polydipsia and your tea and toast diet. In these patients, all I do is fluid restrict, and they correct. In tea and toast patients, I also just say, please eat. If they eat, they usually correct, but unfortunately, these patients who are tea and toast often don't eat robustly, and so it's not that they don't usually overcorrect quickly, but primary polydipsia patients do overcorrect very, very quickly. We'll talk about that at the very end again, what happens if you overcorrect. But let's say, oops, that's not what I meant to do. Let's say instead ADH is very active. If ADH is active, our next goal is to figure out why it's active. If it's because of a low effective arterial blood volume state, well then I have to determine if I'm diuresing or if I'm giving fluid. And this usually helps me overcome that low effective arterial blood volume state. The one caveat to this is when the low effective arterial blood volume state is due to cirrhosis, these patients are often very, very hard to manage and fix their sodiums. There's a reason why sodium is a prognostic factor in both cirrhosis and heart failure, but I find it more so to be very important in cirrhosis, or more frequent in cirrhosis rather. But in both situations, when you see a heart failure patient or a patient with cirrhosis that has hyponatremia, it is a pretty scary sign about how long their survival prognosis might be. Now, let's say that they're not in a low effective arterial blood volume state, meaning RAS is inactive. If RAS is inactive, well, then I'm thinking SIADH versus adrenal insufficiency or hypothyroidism. Let's assume that it's SIADH. This is the one that's really hard because the ADH is usually something very chronic that's hard to turn off. Thiazide might be one exception, which is not a true SIADH but mimics an SIADH picture. But for example, let's say it's like a pneumonia or a lung cancer or um, some sort of SSRI type of thing. These can often be quite persistent in the body for a long period of time. And so this is one of the situations where I have to pull out a few principles. And those few principles are that I have to increase the osmolar intake plus fluid restrict plus minus loop diuretics. Okay, this is the strategy that I'm going to take. Now, why is this the case? Okay, so remember this. I'm going to erase everything but the strategy. Don't know why it's doing this. Okay, if we are this bucket, right? Again, my goal is how do I get rid of H2O? Well, how do we determine how much urine we make? Urine osms, we traditionally just think of as a concentration, which it is. It's the milliosms per liter. But another way of saying is the urine in liters equals the urine osm, messed up there. The milliosms that are able to be used for excretion over the urine osms. Okay, and how do I determine what the milliosms used for excretion are? Well, it's our daily intake. The average American eats roughly 600 milliosms per day, so we have to urinate 600 milliosms per day. Now, if our average urine osmol is 300, we will urinate roughly 2 liters of urine per day. This is where that sort of natural average person pees out 2 liters comes from. It comes from the fact that the average American eats 600 milliosms per day, and that we have a urine osm roughly 300 on average. But in patients with SIADH, they have quite high urine osms, right? Their urine osm might be something like 600. And so if they have a milliosm that's only 600, well, then they'll only pee 1 liter of urine. And if they drink 1.5 liters of water alone or more, well, then they're going to slowly dilute themselves, right? So how do we fix this? Well, we try and increase the top number because we're struggling to change the urine osm, right? SADH is underlying SADH is active. It's going to take a while for it to shut off. And so what we do is we try and change this to 900 or 1200. Okay, and how do we do that? We do that by increasing food, particularly protein, salt tabs, because they are osmoles, not because they're salt, but because they're osmoles that have to be peed out, and urea packets. Okay, so again, I want to make sure we understand salt tabs don't increase the salt in our body. What they do is increase the amount we pee out so we can reconcentrate the salt that we have in our body, because ultimately the salt tabs just get peed out. Okay, ultimately the salt tabs just get peed out, but they drag obligate water with them, and so we reconcentrate the tonic solutes in our body. All right, so by increasing the osmoles, we increase our total urine output, and therefore our fluid restriction allows us to start becoming a little net negative free water per day. Okay, now the final trick here is loop diuretics. Why do loop diuretics work? Turns out the ascending loop of Henle is where we concentrate urine. So when we use loop diuretics, we mess with our kidney's ability to concentrate urine. This is our one way of making our urine osms close to 300. So if they were previously 600, and we were only peeing 1 liter per day because we were eating 600 milliosms per day, but now my urine osm has decreased to 300 milliosms and I go back to I'm still eating my 600 milliosms per day, well, now I'll start peeing 2 liters per day of urine. And so this helps me overcome my fluid, or with a fluid restriction, it helps me slowly remove water from my body. Now this is augmented if I give even more osmols. If I start eating 900 milliosms per day and I use a loop diuretic, well then I'll pee 3 liters out per day and it'll correct my sodium faster. So this is how we approach SIADH. All right. Okay. I think that was a lot of information. Yeah, I think that was a lot of information. And so I want to talk about one final point. I apologize that this is a very long topic. Um, the final thing are situations that overcorrect. So overcorrection. These are situations where we need to be very, very careful. This is hypovolemia, obstruction, primary polydipsia, and finally, adrenal insufficiency. Okay, these 4 situations overcorrect very easily. Why is that? When we give fluid, ADH turns off really quickly and we start peeing really dilute urine. So we start dumping clear urine and you run into trouble really quickly. Obstruction. The kidneys were always trying to do the right thing, so the moment you put a Foley in, they start peeing dilute urine. Primary polydipsia, again, same thing. The kidneys were always peeing dilute urine. We were just outstripping the kidney's ability to catch up to the dilution effect. And so they end up making super dilute urine. Adrenal insufficiency is that once we give the steroids back, ADH is going to turn off, and presumably we fix the volume contraction too, and so it's like hypovolemia, it corrects relatively quickly. In these 4 situations, with my reactive approach, all right, there's really 2 strategies here. One is just go ahead and put them on 3% saline from the get-go plus DDAVP. The second approach is be reactive. Watch the urine output closely, very closely. Sometimes I'll just put a Foley in because I really want strict eyes and nose and determine how fast the urine output is coming out, because then I can trust my BMPs more or less. And when I get close to my goal, once I get close to my goal, I give DDAVP plus minus some D5W if I've overshot a little bit. And the whole point here is that I'm just trying to correct for a day, and then once the DDAVP wears off and I've gotten past my 24-hour period, my next set of 6 to 10 starts, my next 6 to 10 increase goal starts, and I can allow their physiology to correct again and then give DDAVP if I need to slow it down. And so maximum they're in the ICU is 2 days, especially maximum they're in the ICU is generally 2 days. Okay, so again, you can use the reactive or active approach, but you should really have a heightened sense of concern for overcorrection in these 4 populations. Right. Okay, so in summary, I hope we recognize the importance of Edelman's equation in managing hyponatremia. I hope we recognize that hyponatremia, we can go in with a very biased mindset in hyponatremia based on the urine studies, and then hopefully we understand the reactive versus active approach, particularly how much to bolus at a time, don't be ginger with it, how much to use as maintenance at a time, the approach of using DDAVP plus 3% or using the reactive approach. Yeah, so hopefully this helps. Thank you.